Psychiatric History and Mental State Examination, Part 2 of 4. In the last section, we talked mostly about the presenting complaint and the history of presenting complaint. In this section, we're going to talk about the past psychiatric history, the past medical history, the family history, the personal and social history, the drug and alcohol or substance misuse history, the forensic history, the premorbid personality, and the collateral history. Past psychiatric history. What questions do you ask your client when you want to explore their past psychiatric history? At this point, I'd like you to pause the video and write down 6 or 7 questions you would ask your client, discuss them in your small groups. The type of questions you might ask include, what diagnosis have they been given in the past? Who diagnosed them with that condition? Was it their GP or was it their mental health team? Was it self-diagnosed or diagnosed by their family and friends? Have there been any episodes of symptoms where treatment was not sought? Not everybody will seek treatment for their mental health condition or their mental health symptoms, and this could be due to shame or stigma or other barriers. There may be episodes of symptoms suggestive of clinical depression or hypomania in their past psychiatric history, and this could be very relevant now. When did their mental health problems first start? Was it in their teens? Was it in their early 20s? Was it in their early 50s? Who manages their mental health problems? Is it the GP or is it the mental health team? Or is it self-managed? Have there been any admissions to hospital, either informally, which means under a voluntary basis, or formally, which means under a formal or compulsory section of a Mental Health Act? When was their last admission and how long was their last admission? How many admissions have they had? What was the purpose of the admission? Which previous treatments have they tried? Which previous medications have they tried? Have they ever been on a depot? A depot is an injectable, long-acting antipsychotic medication which can be given weekly or monthly. The time interval can vary depending on the medication. Sometimes it's given by patient choice or patient preference. Sometimes patients prefer to have a monthly injection instead of having to remember to take their tablets every day. Other times, it may be something that is advised under a community treatment order. And that means a patient may have to attend to have a depot at regular intervals and be monitored by the mental health team. And this will be under a compulsory community treatment order. And this is usually advised because there have been issues of poor compliance in the past. Have they ever tried psychology? And what psychological therapies have they had? Was it counselling? Was it cognitive behavioural therapy? Was it dialectical behavioural therapy? There are many different psychological therapies available. What was their compliance like with their medications? Did they really take it every day as prescribed? If I give you an example of antipsychotics, when it comes to antipsychotics, to decide whether an adequate trial of that medication has occurred, the patient has to have tried the medication for 4 to 6 weeks and have been compliant with that medication, and it has to be at an adequate dose. And only then can you decide whether that medication is effective or not. And when it comes to psychology, it is an active process, and the patient cannot be a passive recipient of psychology. They have to actively engage. Did they really actively engage with all the sessions? Did they attend all the sessions, or did they miss half of them? Did they really do the homework outside of the psychology sessions to make full use of the psychological therapy? The past medical history is also important. Some medical conditions are associated with psychiatric symptoms. For example, an overactive or underactive thyroid is associated with many psychiatric symptoms, such as depression and anxiety. Medications may have psychiatric symptoms listed in their side effect profile. For example, beta blockers and steroids may cause depression or psychosis. These are uncommon side effects. The family history is also important. In particular, we're thinking about the family history of suicide and mental illness. A history of exposure to suicide in a close family member or close relative is a risk factor for suicide. And a family history of any mental health problem also increases the risk of that mental health problem in that person as well. However, family history or genetics and biology is only one part of causes or risk factors of mental health problems. And when it comes to the causes of mental health problems, it's the interplay of genes and environment that is important. And I've shown this documentary here called Three Identical Strangers to demonstrate that point, because these three triplets are genetically identical. However, in the documentary, one of them develops bipolar disorder and unfortunately ends his life by suicide. So clearly, genetics is not the only cause of bipolar disorder, and that interplay of genes and environment is crucial. I want you to think about the personal and social history. So what kind of questions would you ask your client about their personal and social history? I'd like you to write down 5 questions you would ask and pause the video now. So the type of questions you might ask include, were there any birth complications that they were aware of? Were there any difficulties in their development or any developmental delays? What was their childhood experience like? Did they have any adverse childhood experiences, something we called ACEs? An ACE can be something like bullying or experiencing abuse or neglect, or it can be bereavement or parental divorce. And there's often a cumulative effect when it comes to adverse childhood experiences, and the more adverse childhood experiences people have, the more they are at risk of certain mental health conditions. What was their educational experience like? Did they finish school? At what age did they leave school? How did they do in their exams, and did they get any qualifications? Did they have any learning difficulties? What kind of relationships have they had in the past? Do they have any children? How long did these relationships last? These all give clues to the diagnosis. As an example, people with emotionally unstable personality disorder have difficulty with relationships, and they may have a history of intense and unstable relationships in their past. So this is important to explore in the personal and social history, so that we can get some clues as to what the diagnosis could be. What kind of jobs have they had, and have they had any financial issues? And what is their social support like at the moment, and what is their living situation like? This is important to consider when you're thinking about protective factors and the risk assessment and safety net plan. Have there been any other life events such as divorce, job loss, bereavement, or anything else significant? The drug and alcohol history is really important as well. This is because of the comorbidity of mental health problems. What kind of questions do you ask in a drug and alcohol history? I'd like you to write down perhaps 5 questions you would ask your client about their drug and alcohol use. I'd like you to pause the video now. So which substances do they take? How do they take them? What is the route? Is it snorted, intravenous? Was it inhaled or smoked? And why do they take the drug? How much do they spend on drugs and alcohol? How many bottles do they find in the bin? Not everyone will be able to tell you very clearly how many units of alcohol they drink in a week. So sometimes we have to estimate by asking them how many bottles they drink of which substance, and then using a table to work out roughly how many units they drink. Want to check for dependency and any withdrawal symptoms. So early morning shakes or tremors and sweats could suggest alcohol withdrawal symptoms or alcohol dependence. How is their drug and alcohol problem affecting their life, jobs, and relationships? Do they even see their drug and alcohol use as a problem? Is it something they actually want help with? Is the drug and alcohol problem a primary problem, or is it secondary to something else? Are they self-medicating due to distressing voices? Is the primary problem depression, for example, and are they self-medicating for depression or anxiety or something else by using alcohol and drugs? Forensic history. In the forensic history, we want to find out if they've had any involvement with the police or the criminal justice system. Have they ever been arrested? What for? Have they ever been to prison? And what for? How long did they spend in prison? Have there been any involvement with gangs or other criminal activity that has never come to the attention of the police or the criminal justice system? Again, this gives clues to the diagnosis. So if somebody described in their early childhood that they used to set fires and they used to steal from people, that may suggest that they had a conduct disorder in childhood. In the police custody population or in the prison population, there is a high proportion of patients with antisocial personality disorder. And often with antisocial personality disorder, there is a history of involvement with the criminal justice system. The premorbid personality is not always taken as standard in a psychiatric history. I've noticed that many people leave this section out sometimes, but it can be incredibly useful. You could ask the client, how would they describe themselves before they became unwell? Or how would they describe themselves when they were well? You could also ask, how would other people describe them? The collateral history is essential in some cases, especially so when you don't get a good history from the client in front of you. So it can be very useful to get third-party information, perhaps from the GP, the mental health notes, the family, the friends, the flatmates, and the people who know the client better than you do, or the people who may have noticed changes in the client. And as mentioned, it's especially important if the patient is unable to give you a good history. So that takes us to the end of part 2. In part 1 and part 2, we've looked at the components of the psychiatric history. In practice, the full psychiatric history is not completed on every patient, and we do have to adapt it and select the relevant parts for the client in front of us and for the situation that we work in, or the context that we work in. In the next section, we're going to be talking about the mental state examination.